Our conference for patients and caregivers, and it's good to see many old friends here again. I'd like to begin by thanking Teva for supporting this conference by an unrestricted educational grant. Without them, this would not be possible. So they've heavily subsidized the cost of this undertaking. So let me give my thanks to Teva and their representatives who are here today for their support. I'd like to also acknowledge our debt to the National Parkinson Foundation. So we are a centre of excellence for the NPF. The NPF, the National Parkinson Foundation, supports groups such as ours throughout the country. So there are a number of centres of excellence that really provide tip-top care to people with Parkinson's disease, and the NPF is into a variety of other projects to help people with the disease. So I'm proud that we are a centre of excellence in that organisation. There are a number of individuals I'd like to thank who work in our group. I'd like to thank Aaron Daly. Aaron is over there by the door, tall guy waving. Aaron took over as the coordinator of our Parkinson's Disease Centre earlier this year. He is a psychology major and is experienced in clinical research in a number of different medical settings. He succeeded Jesse Roth, who many of you will remember was our coordinator for the last few years. So Aaron, thank you for what you've done today. I'd also like to thank Ariane Marcus, who I think is somewhere, apparently not. She's our research assistant and she's been involved in a number of our clinical studies, and many of you will probably have corresponded with her about this conference today. Oh, she just walked in. Ariane, can you wave your hand? We also have several volunteers, and I'd like to thank Jamie Wang, Brenda Yu, Tyler Woodward, Alicia Asturias, and Sarah Tong for their help in this meeting today. Thank you. In choosing the topics for today's conference, we've paid particular attention to the feedback that we've received from you in the past. So thank you for that feedback. This time, we're going to get feedback from you, I hope, but in a slightly different manner to how we've done this in the past. Rather than asking you to fill out forms and leaving them here, we are going to send you the evaluation form electronically. And we hope that you will return it to us in the same way. So most of you have probably got your tickets electronically, and the evaluation form will come to that same address. And if you would respond, that's usually very helpful to us in determining future programs and giving feedback to individual speakers. There will be an intermission, as you know from your program. During that intermission, there will be snacks available outside. It's not a meal, and some of you in your feedback say that you really would like a meal. Unfortunately, the cost of that would be prohibitive to us. But there are snacks, and you're welcome to eat them outside or to bring them in or whatever you like, but I'm sorry that it couldn't be a more substantive offering. There'll be a question and answer period at the end, and what I'd like to do is, if you would write down any questions you have, there will be volunteers coming around to collect them, and I can then sort them out into topics and we can discuss them in the question and answer period. Now there's one complication. Dr. Donna Deng, who is an expert on neurology and will be talking to you today about bladder disturbances in Parkinson's disease, can't stay till the end because she has a major teaching commitment at the university and she has to go back for a meeting of the training program, and that can't be put off. So she's very generously volunteered that if you'll write your questions for her, indicate that they are for her, and give your email address, she will respond to you individually by email. I think it's very nice of her. So if you would remember to do that, any questions for Dr. Deng, we will make sure that she gets your questions and she will respond to you in a very timely manner. I'm sure that many of you know that the bathrooms are just outside and to the left, men and women bathrooms, male and female bathrooms. I think I've covered everything, but I know Marianne Domino, who was our nurse coordinator for about 10 or 12 years, and subsequently has been leading our outreach program as a volunteer, also have a few moments.
Greetings, everyone. Nice to see these familiar faces. I just want to make a very quick announcement. There's going to be an NPF walk for Parkinson's disease April 19th. There is a table outside for NPF which will give you information. We encourage any of you to participate in that walk. I think it's a real strong commitment in the community to bring awareness to Parkinson's disease and to do some fundraising for the National Parkinson Foundation. We also have hospital kits. If any of you do not have one, the NPF, and we actually worked on this project, developed hospital kits that you can take to the emergency room or to the hospital if you should be hospitalized. It's very, very helpful. We've gotten great feedback, so make sure you pick one up when you leave today. I want to say thank you to all of our community partners who are participating and have tables outside. In case you haven't gotten to see them, I want to alert you, Medtronic, NuPro, Fight Back, Dance PD, exercise classes, support groups, and other materials are available for you. So please take advantage of that. The other one thing is, if any of you are not on our email distribution list for the conference, but would like to have information sent to you about educational activities, there will be sign-up sheets outside. Please put down your name and your email address so that in future, if certain things come up, we can notify you and you can decide whether or not this is something of interest to you. So I will turn this back to Dr. Amro.
Thank you. Well, I think all I have to do now is introduce our first speaker to you. Dr. Caroline Tanner, or Carly Tanner, is the director of our Parkinson's Disease Research, Education and Clinical Center at the Veterans Hospital. Just so that you are aware, the Veterans Administration some years ago set up these PADRECCs, as they're called. There are only 6 in the entire country, and one of them is in San Francisco, and it's Carly now who directs that. She's been with the UCSF for the last year or so, and previously was at Sunnyvale at the Parkinson's Institute there. She's a professor of neurology here at UCSF. She's well known for her many studies on clinical epidemiology, in particular on environmental and genetic determinants of Parkinson's disease, on studies looking for biomarkers of the disease, and studies aimed at early detection of the disease. She's a past co-chair of the Parkinson Study Group. The Parkinson Study Group is a national collection of investigators who collaboratively work on questions concerning Parkinson's disease and treatment trials and so on. And we are members here at UCSF, and Carly is a past co-chair, as I say, of the Parkinson Study Group. She also serves on the Scientific Advisory Board of the Michael J. Fox Foundation, which many of you will be familiar with, and also on the National Spasmodic Dysphonia Association. And she served on many other committees for the National Institutes of Health and the American Academy of Neurology. So Carly, thank you so much for coming on today, and we look forward to your talk on epidemiology of Parkinson's.
It's a true pleasure to be able to speak with you today. And today I'm going to talk about some of the work that my colleagues and I have done trying to understand the causes of Parkinson's disease, and particularly taking the approach of an epidemiologist. So as an epidemiologist, we look at populations and look at patterns in populations and use that kind of big picture to try to understand things about causes of disease. So one thing that we do know about Parkinson's disease is that the numbers of persons who have Parkinson's disease increase as the age of the population you're studying increases. So new cases are much more common after the age of 50, very rare before the age of 50, and as you can see, these kind of, do I have a laser pointer? Yeah, these increasing lines mean that by the time you get to age 80, they're even higher. Another thing is there's a preponderance of men, so men more than women are at risk for Parkinson's disease. Why is this important? Well, of course, it's individually important to any of us who deal with Parkinson's disease, but it's also important in a global sense because life expectancy is increasing worldwide. So this is a graph that shows on the very far left 1950, on the far right 2100, and those upward curves are life expectancy starting with birth for people all over the world and in every continent of the world, right? So more and more people will live to the age at risk for Parkinson's disease. This shows just the most populous countries and developed countries, and red is more than 100% growth by 2030 from 2005. Blue is 50 to 100% growth, so dramatic increases in the numbers of Parkinson's disease just in this short little time period. Obviously, if we can't figure out a way to stop it, many more as this goes into the future. So for society, their consequences are the cost of healthcare, of course, but maybe even more importantly, what we call indirect costs, so the loss of years' work, the societal contributions of people with Parkinson's, their mental and physical costs for the person with Parkinson's and for their family members, their friends, their colleagues, and everyone in our community. So I know everyone here understands that very personally, but these are intangible but critically important things to all of us, and important for us to be able to bridge the gap, understand how we can stop this, you may recognize that bridge, right? How we can really block these, fill these knowledge gaps, address these unmet needs. And so that's some of the work I've been trying to address in my studies of the causes of Parkinson's disease. So knowing the cause can help us with better treatments. It can help us find people at risk so that we could intervene and maybe prevent the disease, or at least slow or delay the onset of disease. So, what do we know so far? And I'll focus a lot on work that my group has done and a little bit on others. So, the first clue came from the Parkinson's Institute, which wasn't existing then, but from Bill Langston, Jim Tetrud, and others who identified what we call a cluster. So, a group of individuals who had the relatively rapid onset of Parkinson's disease, and they did some detective work, and they found, these were younger people. They're in their 40s, mostly 30s, some of them. They had the same signs as Parkinson's. They had progressive worsening. So clinically, it looked like Parkinson's. If you gave levodopa, they have a therapeutic benefit. And they even had the same side effects as people with typical Parkinson's get from levodopa. But the culprit was, this is a garage, and this is where a person was making an illicit drug, a narcotic drug that they were selling. It was called a designer drug. It was technically legal back then. It's not now. And it was a way to get around drug control laws. And they took a wrong turn and came up with something that was a poison. And these people turned out to all be narcotics addicts and had injected this poisonous version of the drug they were trying to make. And they all developed Parkinson's in a short period of time, within a couple of weeks. So obviously, this is not the reason the people in this room have Parkinson's disease, right? And people don't inject themselves with narcotics, and most people with Parkinson's disease don't have this MPTP exposure. That was the name of the chemical. So it's not a likely cause of Parkinson's, but the effects of MPTP were able to be studied in the laboratory, and that led to a lot of clues about what might cause Parkinson's disease. And also, it was observed that the structure and the function of this chemical are in fact very similar to a number of other chemicals that might be environmentally present. So it led us to be really interested in trying to understand whether there were environmental causes of Parkinson's disease. So this was, in the early 80s. I was a young neurologist just kind of starting my career, and it really triggered my interest in this, and I went on to get advanced training to be able to do a better job of trying to look at this. So it led to the question, is Parkinson's an environmental disorder? Well, just a little bit later than that, colleagues in New Jersey, Roger Duazan, Larry Golby, and others, were studying this big family that started, they noticed it first in New Jersey, but the roots went all the way back to Italy and to Greece, and they saw a pattern of inheritance that passed from one generation to the next. So this is called a dominant pattern of inheritance, and they put forward the idea that Parkinson's is an inherited disorder. There's no environmental factor at all. It just passes from one generation to another, and we just need to be good enough to find the genes underlying it, and that would explain all of Parkinson's. So there was a big question. Is it due to something you might be exposed to in the environment? Is it due to something you inherit from your parents? And so that led to a study that we did looking at twins. So this was a long time ago now, in the late 80s, and it was before, or I guess early 90s, but before we had all the fancy genetic tests that we have today. So what we did was we did an observational study. We found a group of twins who were World War II veterans, had been studied originally for heart disease, cardiovascular risk factors. We got a list of the names of all these 20,000 individuals, called them up on the phone and asked them some screening questions to identify people who might have Parkinson's or those who didn't. And then we went out to their homes all over the US and examined them, because that's what you have to do to diagnose Parkinson's. As you know, there's not a blood test that really gives you the diagnosis. So we looked at the twin, and we looked at the twin's brother, whether the brother is thought to have Parkinson's or not. And what we were looking for was the idea that if it's an inherited disorder, MZ twins or identical twins have the same DNA, they have the same inherited predisposition. And so if one twin has Parkinson's and it's a genetically determined disorder, the other twin should have Parkinson's too. So, and then for DZ twins, so dizygotic twins or fraternal twins, they should be related just like any other brother. And so you would expect a lower rate in the DZ twins. About 50% of their genetic material on average is shared, while it's almost 100% in the identical twins. And so we wanted to see a higher rate in the identical twins if, in fact, the idea that this is an inherited disease was correct. So that was our hypothesis. What we found was that wasn't the case, right? So we found low concordance, meaning relatively few individuals in any of the twin pairs both had disease. If one brother had the disease, most of the time the other brother did not. On the other hand, in the very, very younger age at onset, people under the age of 50 when their disease started, we did see an excess of the identical twins. So it suggested there is a hereditary component. It focuses on the younger age at onset. And in typical disease, onset after age 50, there doesn't seem to be a strong hereditary component, okay? So that led us to be interested in looking further at environmental contributions to the disease. So now that was then, and now we've been able to study a lot of families where there is inherited Parkinson's. We've understood that there are some complexities to this. So there are at least about 10% of people with Parkinson's who do have a single genetic defect that is one of the major determinants of their disease. Some of this is inherited at the early age, as we found in our twins, and some of it is more common. It looks like typical Parkinson's, but it has what we call reduced penetrance. So reduced penetrance means you can have the gene and you can live throughout your life and you may not get disease, while another person can have the gene, and for reasons we don't understand yet, that person may get the disease. So it makes the patterns in families, not the 100%, father to son to daughter, the way you might expect it to be. And so we now know that, and we're actively studying that as well. I'll give you some follow-up on that. But even then, most of the time, there isn't a genetic defect that we can identify that causes Parkinson's. So for most people, it seems that still isn't the predominant reason people have disease. What we were able to do, though, is take all these genes that have been identified within families with rare forms of Parkinsonism and study them in the laboratory. And this leads to really important clues to the causes of disease. So back and forth from studying families into the laboratory, studying the effects of those genes, that leads to ideas about what might cause Parkinson's. So another thing we were able to do is, since we realized that genetics wasn't the primary cause in our twin pairs of Parkinson's, and most of them, we could look at the pairs where one twin had Parkinson's and the other twin did not, and look at what else was different. Because one of the great things about twins is that they do have so much in common that if something's different, it's a pretty big clue that maybe that's important in terms of causing Parkinson's. And so this is just an example of some of the work we did. This is looking at the idea of head injury and risk of Parkinson's, and this is in that same population of World War II veteran twins. And what we found was that, in fact, head injury was associated with an increased risk of disease, so about 3 times more. It was a little bit higher in the identical twins than the fraternal twins. And if you had more than one head injury, you had an even higher risk than someone who just had a single head injury of getting Parkinson's disease. Moreover, that head injury happened a long time before the disease onset. So this wasn't maybe having a little bit of a balance problem that wasn't detected yet, and then being, predisposed to an injury because your Parkinson's was just starting. This was like 3 decades before the onset of disease on average. So it suggested that there's something that happens when people have a head injury that then causes a trigger that goes on eventually, in some people, to manifest as Parkinson's disease. On the other hand, head injury is not universally associated with Parkinson's. So this is just a sort of a graph that shows studies looking at it, and about 70% of those studies found on the far right increased risk, but not all of them. And there's a biologic plausibility, as I said. There are things that we think, when we look at animal models, might be associated with Parkinson's risk that get triggered by head injury. But it's still true that lots of people have head injuries, and only some people who had severe head injuries end up having Parkinson's disease. So why might that be? So this led to what's been the major focus of the study of my group for the last number of years, and that's looking at what's called a gene-environment interaction. So basically, what that says is that you have a hereditary predisposition, but if you don't have the environmental insult, whatever that might be, then you don't manifest the disease, in this case, Parkinson's disease. So here's an example looking at head injury and an example of gene-environment interaction that we've been able to look at. So the gene is alpha-synuclein. The environment is head injury. So alpha-synuclein, as many of you probably know, is a really important protein in Parkinson's disease. It's the constituent of what's called the Lewy body here, which is the main thing that people can see when they look under the microscope after someone's passed away, that says, yes, that's actually typical Parkinson's disease. So it's a very important pathologic hallmark to help with the diagnosis after someone's passed away. So we're sure it's really Parkinson's disease we're looking at. It's also the protein, the gene that codes this protein is the one that was abnormal in that big family I mentioned to you that Larry Golby and Roger Duvoisin studied that led them to think perhaps there was a dominant inheritance. So it's an important protein in Parkinson's disease. People who have, looking in the animal models, head injury is increased alpha-synuclein both in animals and also in people after brain injury. It also causes increase in inflammation. It interrupts what's called the blood-brain barrier, which protects the brain from toxic chemicals, and causes other things that we think might be related to Parkinson's disease risk. So it led us to wonder whether having changes in the gene, not the ones that cause disease, but just maybe make the alpha-synuclein a little bit dysfunctional, might affect your risk of head injury. And so what we did is we looked at some variants in the gene that may have an effect on how the gene actually works in the body, not enough in most people to cause disease. So we found maybe a very tiny increase in disease with this variant number 2 compared to variant number 1. But if you looked at the risk from the gene, the risk from head injury, and the risk of both all together in the same population, what you found was you have about 50% increased risk if you had just the variant, 70% if you had just head injury, but if you had both, you had 1,000% increased risk of developing Parkinson's. So this is an example of gene-environment interaction. If you didn't have the environment or you didn't have the gene, your risk was really tiny, but if you had both, pow, you had a much higher increased risk of disease. So it leads to this general idea about Parkinson's that it's a complex disorder, right? Here's a simple way of thinking about it. Genetics loads the gun, so that's the DNA. Environment pulls the trigger, right? So if you don't have both, you're probably not at risk. So it's an idea that actually underlies a lot of other disorders as well, heart disease, diabetes type 2, lots of other common diseases are complex. You're going to have a predisposition and then environment, lifestyle, chemicals, whatever, also modify it. So we're thinking this is, for most people with Parkinson's, the reason that people have disease. And we're now interested in kind of exploring this in more detail, which is kind of challenging. So the next thing we looked at in terms of environmental causes was the idea of whether or not pesticides might be associated with increased risk of disease. And as you can see here, many studies around the world, all those little red dots, have found that there is a modest increased risk in Parkinson's if someone has been exposed to pesticides. But these studies looked at really broad categories of pesticides and weren't able to look at very specific agents. We were interested in this at first because we know that MPTP looks very much like certain pesticides and acts in the body like other pesticides. So it made us be interested in looking at the whole question. This is one of the studies that my group and I did looking at risk factors for Parkinson's, and this was in people who were in Parkinson's clinics and then what we call controls, so people theoretically just like the person with Parkinson's, same gender, same age, coming from kind of the same population as far as socioeconomic factors, but without Parkinson's, and making that same kind of comparison to look for things that might be different. We took really detailed histories, looking at their occupations, not just their jobs, but the tasks that they did, because it's your job task that determines what your exposure is. Took hobby histories and risk factors, lifestyle factors, and what we found was there was an increased risk associated with the pesticide, the herbicide paraquat, which just coincidentally is very similar, except for one little side chain, to MPTP, and has a mechanism of increasing oxidative stress we thought might be related to Parkinson's from animal models. And then also another one, 2,4-D, a similar increased risk. This hasn't been much studied in the laboratory, but interestingly, 2,4-D is one of the components of Agent Orange. And at about the same time, the Institute of Medicine determined there was likely an association for people who are Vietnam vets between exposure to Agent Orange and increased risk of Parkinson's. So it was sort of coming from two directions, suggesting 2,4-D, in fact, may be another factor increasing risk of disease. We then went on to look at another population. These are farmers who are using pesticides every day, and farmers, because of their business, have to keep track of everything that they use. So we have very good exposure histories of what these farmers were doing, and we collected lifelong histories from 52,000 farmers and 30,000 of their spouses, and living in 2 states that we were studying. And we found about 100 people with Parkinson's. We since have a lot more, but this is what we had at that time. Did the same thing. We went out into the farms, we examined them, we collected, samples from individuals and samples from the farms, and took very long histories as well of all the things they had done occupationally, all the pesticides they'd used throughout their whole lives. And we found, again, an increased risk associated with paraquat, that MPTP-like chemical. And also rotenone, which is interesting because rotenone is a naturally occurring compound that's derived from roots and leaves of plants, lots of different plants actually around the world, and has been used as a natural pesticide that people have approved for a long time for organic gardening. It is something that works exactly at the same spot in the body, in the mitochondria, and the energy storehouses, as does MPTP. So it was really another sense of really this makes sense that rotenone might increase disease risk. And what we found was that rotenone was about the same as paraquat, about a twofold increased risk of disease. Rotenone is something that isn't very much used now, but up until maybe about 10 years ago, it was fairly ubiquitous. So it was in, like the stuff you dusted on your African violets or what you put on your dogs for fleas. So plausible that lots of people could have rotenone exposure and not really know about it. We also looked at the question of gene-environment interaction in terms of exposure to paraquat. So GST is an enzyme that is responsible for breaking down chemicals that get into the body and shouldn't really be there, right? And this one form of GST can either be present or absent in the body. And if it's present, and you have a paraquat exposure, lo and behold, you don't have any increased risk of Parkinson's. So this is people with the normal gene, and if they have paraquat exposure, they still don't have an increased risk, right? So one is normal, no risk. If they have the mutant gene that doesn't code for this particular protein, and they have a paraquat exposure, they have a much more dramatically increased risk, so almost more than 1,000 times the risk of developing Parkinson's disease. So another example of gene-environment interaction, if you can break down the toxic chemical, you're not at risk. If you can't break it down and you have the exposure, you are at risk. This is something that we're now pursuing. We're just starting some additional studies based on this one original one where we've looked at the twins again and found exposure to solvents, trichloroethylene, perchloroethylene, and also a little bit carbon tetrachloride. And these are all chlorinated solvents. And just by themselves, without even looking at gene-environment interaction, they're associated with a 6 to 10-fold increased risk of Parkinson's. So perchloroethylene is commonly used in dry cleaning fluids until fairly recently. Trichloroethylene is a really common industrial solvent for cleaning things, and they're both what we call environmentally persistent, meaning that they don't break down very much. So the active chemical can accumulate in the environment, can be in the drinking water, can be in the soil. And so there's a possibility that people could have exposure to these and not be aware of it. We looked at occupational groups where we could document what their exposures were. So we're pursuing this in a number of ways now to try to understand more about that association. Another logical question is, what if you had more than one environmental exposure? Can this influence your risk of disease? So we looked at the combination of head injury and paraquat use and found, in fact, just as you might suspect, if you had both head injury and paraquat use, you had about a 4-fold increased risk, whereas if you had just one, your risk was only slightly 20% or 80% increased. So yes, it looks like there is some synergy between multiple environmental exposures. So where does this leave us? It leaves us with the idea that genetic disease by itself is rare, environmental-only disease by itself is rare. Most Parkinson's is the combination of genes and environment. And to me, this is a very helpful finding because it's hard to change your genes, but environment can be modified. And so to be able to identify environmental causes and modify it either by our own behaviors or by legislation or changes in industrial practices can lead to a really big difference in terms of Parkinson's risk. So a hopeful approach. And so secondary prevention is one of the things that is a big focus of our interest now. So secondary prevention means identifying people who are at risk for Parkinson's before they manifest the symptoms. So, and then intervening so you can stop the disease, right? Giving them a treatment, a benign treatment that stops disease and doesn't cause side effects. So ways to try to do this would be looking at factors that might lower Parkinson's risk. So I've talked about some of the ones that increase risk, but there are also environmental factors that lower risk. and we need to study those as well. One is cigarette smoking. It's been seen forever. Doesn't mean you should go out and start smoking to prevent Parkinson's, but it does give us clues, and one of the big clues, of course, is nicotine. So right now, in fact, there's a study looking at people with early Parkinson's to see if nicotine can slow progression, because nicotine has effects in the brain that may be beneficial and slow progression of disease. So we're testing that. Physical activity is an important one. There are mounting studies showing that physical activity, moderate exercise, can lower disease risk. This is something everybody can do. It has no side effects. It's also beneficial if people already have disease. It seems to slow progression of disease. If you don't have disease, moderate physical activity may be one way to help prevent it. And of course, it's good for many other health reasons as well. Drinking coffee or tea in a number of populations seems to lower disease risk. It does affect chemicals in the brain that we're exploring as, possibly neuroprotective mechanisms. So again, these aren't proven, but there are hypotheses that we're exploring. Higher serum urate is another thing that we're looking at. So uric acid is a constituent that in high normal levels in the body is associated with a lower risk of developing Parkinson's. So now there's a trial that has been completed that suggested this may be true. Just elevating people's urate a little bit may be associated with lower risk of disease, and a bigger trial is probably going to be starting soon. Female gender is associated with a lower risk. We don't know why that is. We don't actually have a good strategy at this point. Using estrogens doesn't seem to be helpful, but we're trying to investigate this further. Higher vitamin D is another one of these sort of no-brainer things. Lots of people are vitamin D deficient. People with Parkinson's disease definitely have lower levels of vitamin D. Taking vitamin D to make sure that you're at the appropriate levels is an easy thing to do. Exercising out of doors is an easy way to up your vitamin D, because most of your vitamin D comes from sun, but supplements would also be a way to approach this. Lots of questions about diet. It seems that a healthy diet that's kind of high in certain kinds of sort of Mediterranean diet, high in grains and fresh fruits and vegetables, low in animal fats is one that may prevent developing Parkinson's. And then there are some questions about other kinds of drugs that are being explored. So there's a trial right now looking at calcium channel blockers to see if those might slow progression of Parkinson's. So we're investigating these things in the laboratory. So far, the studies that we've done, unfortunately, for all of these things, haven't really come up with a home run. We don't have a yes, this will prevent Parkinson's. It could be because the treatments we've chosen to look at don't work. It could also be because we're starting too late. We're starting with people who already have had Parkinson's for years. Even if they're very early, they probably have had disease at least for a couple of years. And we know at the time of diagnosis, on average, people have lost about 50% of the neurons that are responsible for some of the motor symptoms of Parkinson's. So one thing we'd like to do is move back to what we call the prodromal phase. So we now know that loss of smell sensibility, constipation, rapid eye movement, sleep behavior disorder, changes in cardiac function can precede Parkinson's in some people by decades or at least 10 years. And so if we can identify people at that point with those symptoms, not the motor symptoms of disease, and intervene then, maybe we'll be better at slowing disease progression. So that is something that we're really interested in exploring, or even, if we could, getting to that preclinical phase before any of these features are present. So how can we find people at risk for Parkinson's? Well, the features I just said would be one possibility, people who have loss of smell sensibility, etc. Another possibility are people who have the risk genes. They either have a gene that could be causative by itself or multiple causes of Parkinson's from other susceptibility genes. Or people with toxicant exposure, people with lots of pesticide exposure, for example. So these are all categories that may be at risk for Parkinson's. The problem is lots of people have any of those features and yet never do go on to Parkinson's. So trying to figure out a way to study this is just on the basis of those characteristics is very challenging. So the next steps are to come up with what we call biomarkers. biomarkers. If we could have a blood test, for example, that said, oh, this is a person at risk for Parkinson's, it would be easy to then say, this is somebody who maybe we should give this treatment that might help lower their disease risk. So one study like this that we're about to begin here at UCSF is called the Parkinson Progressive Markers Initiative. It's funded by the Fox Foundation. And what we're doing is we're looking at groups of people with either early Parkinson's, healthy controls, REM sleep behavior disorder, some of the genes that are associated with familial Parkinson's or reduced smell sensibility, and then studying them further to try to identify prospectively biomarkers that may be associated with either developing the disease or progression of the disease. If we can come up with a blood test, or we're looking at spinal fluid, a spinal fluid test that gives us that kind of clue, that would make it much easier to do these investigations. So what about altogether preventing Parkinson's? Not secondary prevention where you take someone at risk, but you actually get rid of the causative factors so people don't even get to a risk stage of Parkinson's disease. Is that a possibility? That disease process is never initiated. So this is just a little teaser from our work in the agricultural health study, the farmers with pesticide exposure. What we looked at is that use of what's called personal protective equipment. And this shows you, whoops, it didn't come out quite right, but this line should be down here. So people who have an increased risk of disease have up above this line, right? And what we found was that people who were exposed to either paraquat or another chemical, permethrin, that's associated with a higher risk of disease, and who used personal protective equipment were not at increased risk of disease. So this means gloves, washing off if you have a spill, and you get chemicals on your body, things like that. People who didn't use personal protective equipment were at a greater risk of disease. So this is a really simple take-home, right? Just basic hygiene and education for people who are pesticide applicators that suggests you can actually do primary prevention and never have the disease process start. Just to finish up, I'll just mention work that we're just now launching here in California. So some of you may know there's been an advocacy movement over the last 10 years or so that Parkinson's disease is technically what we call reportable in California for the purposes of research, right? And the state of California theoretically would be mounting this effort, but the state had no money. And so as a result, my colleague Beata Ritz at UCLA and I had a pilot project where we found people with Parkinson's disease by going out and collecting the names from healthcare providers in 4 counties, Santa Clara County and then 3 counties in Southern California. And the advantage of this is that if you can get all of the people in a population, so you're covering everyone and not just people, say, in one clinic or the people in this room, then you can really look accurately at what are the determinants of disease risk and feel like you're exploring that risk in everyone. So what we're doing is we're working with the state of California. We're mapping the addresses of everybody in terms of where they lived in the state and where their life has been over time. And then we can compare it to the pesticide monitoring and the other toxicant monitoring that has happened in California since the 70s or earlier, and do what we call a geocoding, where we can look at, say, this shows areas where paraquat has been used. This is mixtures of different chemicals in water. This is exposure to that chemical I told you about, trichloroethylene, which is environmentally persistent. And look at whether you lived near to a place where you might have been exposed to this, even if you weren't working with it. And that may give us some more clues, first to cause, and then hopefully to prevention. So as you can see, it's a multidisciplinary process to understand Parkinson's. Clinical researchers, clinicians, basic scientists have to work together, and most importantly, the volunteerism of all the people with Parkinson's who help with these studies are critical to our understanding. So I'll end with thanking the many people who supported this study, or these many studies, and particularly the research study participants and their family members. Without you, we really wouldn't be able to have any progress at all. So thank you very much.